I will talk to you about how to do, or how I was taught to do cervical ablations of the medial branch nerve. I have no disclosure other than the fact that I am a huge fan of the Spine Intervention Society, and I'm a member, and I became a member specifically for the purpose to buy their second edition of their guidelines for interventions. The first guidelines came up in 2003, and the second edition came up 10 years later in 2013. So I'm hopeful that they will come up with another edition in 2023. As you will know, or you may know, they used to call themselves ISIS before removing the I from the acronym for obvious reasons. So the cervical facets or zygapophyseal joints are true joints, true synovial joints that are located between the inferior articular process of one vertebra and the superior articular process of the vertebra below. They are usually located behind the plane of the intervertebral foramen and the plane of the spinal nerve that is contained within the intervertebral foramen. You know that is an important anatomic distinction and information for when you perform the radiofrequency ablation procedure, because you don't want the tip of the needle to enter the intervertebral foramen, obviously. They are relatively small joints, and they have a capacity of not more than 0.5 to 1 milliliters. So every time you decide to perform an intra-articular injection, be cognizant of the amount of contrast that you inject within the joint first, and the amount of volume that you want to inject within the joint after you have confirmed that the needle is in the correct position, to make sure that whatever you inject does not leak out. They are the joint innervated by, as you know, by the medial branches of the cervical spine, spinal nerve dorsal rami. The medial branch innervates not just the facet joints, but innervates a bunch of other important structure, including the deep cervical muscles such as multifidus, semispinalis, cervicis, and interspinalis. They usually are located around the anterolateral, lateral, and posterolateral aspect of the ipsilateral articular pillar, as you can see in this diagram. A brief review of why you do what you do and what the most appropriate indication for the procedure is. You perform an RFA of the medial branch nerves after you ideally have performed 2 medial branch nerve blocks with 2 different types of local anesthetic, and you have achieved, according to the SIS guidelines, they state 100% relief of pain, something that is extremely difficult to achieve, but a percentage of pain relief that you and your patient are comfortable with, 75, 80% at least. In the guidelines, they even advocate the possibility of doing either 2 controlled diagnostic blocks with 2 different types of local anesthetic, but they may even suggest the possibility of doing 3 blocks with 2 different types of local anesthetic and a third sham injection with whatever solution you want to use, saline in particular, and completely blinded to operator and patients, and then after the 3 procedures have been completed, unfolding the blindness and see what the results are. Obviously, something that is not possible here in this country. So we are suggesting and recommending always to perform 2 controlled diagnostic blocks, because it is important for you to know that at least at the lumbar spine level, if you perform one diagnostic medial branch block of the lumbar medial branch nerves, you have between 38 and 45% chance of having a false positive response. Something that significantly drops down to almost 0% if you do a second diagnostic medial branch nerve block. And that possibility of having a very high percentage of false positivity increases as you perform this procedure higher up into the spine. The most important piece of information that you need to have is this one. In order to place the needle for a medial branch nerve radiofrequency ablative procedure, the tip of the needle must lie parallel to the plane of the facet joint, as you can see in diagram C, or lying parallel to the medial branch nerve along the waist of the articular pillar, as you can see in image D. Image C is a lateral view, and image D is an oblique view. Oblique probably between 25 and 30 degrees. In this image, you will see that if you place the tip of the needle within the dash parallelogram, you have correctly placed the tip of the needle to perform an RFA of the C3 through C6 medial branch nerves. If you place the tip of the needle into the dash triangle at the C7 level, you have correctly placed the needle to perform a C7 medial branch nerve radiofrequency ablative procedure. This is, as you can see, it is a lateral view. Now that you know where you need to place the tip of the needle in order to place the tip of the needle correctly, you can reach that needle using two types of trajectory, two types of approaches. You can use an oblique path. That means that you will have to start doing the procedure placing your C-arm in an oblique view, usually 30 degrees angle from the sagittal plane. Or you can use a sagittal path. That means that you can start your procedure placing the needle on a lateral view and placing the needle parallel to the plane of the corresponding cervical facet joint. This is these are pictures of a needle that is inserted through an oblique view pass, and you can see that the tip of the needle is moving toward the anterolateral aspect of the C5 articular pillar, and you can have a lateral view on image A and a AP view on image B. You can see that the tip of the needle is lying behind the posterior margin of the foramen on the lateral view, and you can see that on the right image on the AP view, you can see the circle that indicates where you can place the tip of the needle for a second lesion at that particular level in the waist of the articular pillar. This is instead the same procedure performed using a sagittal lateral view pass. You can see that the tip of the needle on image A is located on the dorsal aspect of the foramen, and you have an arrow that will tell you and will indicate where you can place the needle for a second lesion at that particular level. And you have the same image of a second image of the same needle on an AP view with the circle that indicates where you can place the needle for a second lesion at that particular level. So this would be reaching your target using a lateral view approach, a sagittal approach, and the other views that I have shown you before will be basically doing a similar procedure using an oblique view approach. This is the image for the placement of the needle for the performance of the C7 medial branch nerves ablation. On the AP view, you can see that the needles have to lie against the lateral surface of the superior reticular process across the top of the transverse process of the C7 vertebra. You can see that you can perform multiple lesions in order to capture multiple possible locations of the C7 medial branch nerve on the transverse process from the base, excuse me, not the base, from the base to the apical tip of the superior articular process. And as you can see, as you have shown you in the picture before, where you need to place the tip of the needle in that dashed triangle in order to achieve the correct placement of the needle to perform this type of procedure. Sorry, this is. These are pictures of the tip of a needle placed for a C7 medial branch RFA. You have image A. You insert the needle via a sagittal pass, meaning using a lateral view across the lateral aspect of the C7 superior reticular process. And again, the circle indicates another location for a second lesion at that particular level. And the lateral view shows you the needle line across the lateral aspect of the C7 SAP, and you can place and the arrow indicates areas where you can place the needle above and below to perform other lesions at that particular level. For the third occipital nerve, the third occipital nerve is located along the location where you can place the needle to perform a third occipital nerve block / ablation lies on a vertical line that bisects the C2-3 facet joints, as you can see in picture A and in picture B. That's because they are, all the target points for this particular nerve are embedded in the pericapsular fascia of the C2-3 facet joint. As you can see in this image, you can see lateral view of the cervical spine with a needle placed in the middle of the three portions required to block the third occipital nerve, and the white dot show you where the other two locations of the nerve is, so that you can potentially place needle at those levels and obtain an adequate block of that particular nerve. Here instead are images that are lateral views and AP views with a needle that is placed in the high, mid, and low position respectively. And you can see lateral views for A, B, and C, and AP views for D, E, and F. Okay? Any questions so far? Okay. So physics of the RFA. Usually, this is the way that the geometry of a lesion of a radiofrequency ablation procedure generates. Usually, the volume of tissue that is coagulated has an elliptical shape in longitudinal section and the circular shape in the transverse section. The usual recommended temperature is 80 to 90 degrees, no more than 90 seconds. After 90 seconds, it's further growth and further growth of the lesion is limited by the coagulated tissue because the coagulated tissue present an increased resistance to the flow of the current. So using higher temperature doesn't necessarily give you better results and may not make a lot of sense. For the cool RFA approach, in the cool RFA approach, the impedance is kept low around the electrode by cooling it with water that is usually passed through a channel incorporated into that electrode. The low impedance around the electrode allows current to hit tissue for a longer period of time and allows you to coagulate a larger volume of tissue. Usually the temperature used for a cool RFA is between 45 and 50 degrees. And they have the tendency to extend more distally than do lesions that are performed using the monopolar RFA technique. Usually, the way that RFA works is coagulates proteins in situ, and it does not breach the nerve. Usually, you recover from the RFA because there are some endocellular mechanisms that clear the coagulated proteins inside the axons of the nerves, and you have persistent pain relief as long as the nerve is coagulated. As soon as the nerve starts to recover and the nerve ability to conduct painful impulses resumes, then pain can recur. You obviously should try to do all the efforts to maximize the length of the nerve coagulated so that you have optimal results for the longest period of time possible. So is this an effective procedure? In this article that was published not too long ago, not very recent though, in 2016 in Pain Medicine, who happens to be the official journal of the Spine Intervention Society, they performed this systematic review with comprehensive review of data available up to that time. And you can see that on average, at 6-month period, usually between 60 and 70% of the patients have adequate analgesic response to an RFA. That adequate analgesic response starts to decline quite significantly after 6 months. At the 12-month period, usually on average, not more than 35 or 40% still have an adequate analgesic response. What is an adequate analgesic response? We are talking about at least more than 50%. Like everything that we do in pain medicine, whenever we decide to place a needle into people's body, we run the risk of having some problems, some risks, some complications. What are the most common possible complications with this type of procedure? Well, you can cause injury to the spinal cord if you place the electrode way too medial in relationship to the location of the facet joints, passing with the tip of the needle into the vertebral canal and entering into the spinal cord. You can injure the spinal nerves. You can place the tip of the needle into the spinal artery and or the vertebral artery. If you place the electrodes too medially, way anterior to the target zone for the cervical medial branch. These cases have been reported in 2008 in Pain Medicine, and actually the first of these two cases, the injury to the spinal cord, was performed with the patient under general anesthesia. It goes without saying that any of these procedures must not be performed with the patient under general anesthesia. Other possible complications, you can have pretty significant denervation of the cervical spine musculature. Interestingly enough, 2 cases of the so-called dropped head syndrome have been described. Drop head syndrome is a post-procedure kyphosis that is due to extensive denervation of the extensor muscles, and it's been reported in the literature twice. So limit the number of nerves that you have to coagulate, not more than 3. I'm not a huge fan of placing multiple needles on the same patients and doing multiple injections and multiple denervation at the same time. I always ask patients whether or not one side bothers the patients more than the other, and I usually start with that side. And if I can limit to that side, I am more than happy to limit the intervention to that side only. Actually, this case needed some kind of surgical repair to fix that. So you want to avoid something like that at all cost, and you can avoid that by not necessarily being overtly aggressive. Ataxia is a very common side effects of third occipital nerve RFA. The third occipital nerve plays a significant role in cervical proprioception and has a very constant cutaneous distribution. If you place the needle in one of the 3 locations that I've shown to you on those images, it's pretty a given. It's pretty for sure that you are going to develop temporary ataxia and numbness. So in order to limit the risk of ataxia as much as possible, try to limit that by performing only one third occipital nerve RFA at a time. If a patient has both sides that need to be addressed, try to address the side that hurts the most first. And then if you need to go on the opposite side, decide if you want to go on the opposite side by maybe repeating a third occipital nerve block first, and then decide whether or not you want to go and do an RFA on that side as well afterwards. Usually have a few weeks pass between RFA so that the patient recovers from the first procedure before you proceed with the second intervention. This is the same articles that I've shown you a few moments ago, in which they show you that there are multiple side effects, multiple complications, potential related to the performance of this procedure. The majority of these are temporary, they are minimal, they have described some enduring cutaneous numbness, and then I found very interesting that enduring one case of Koebner's phenomenon that I didn't even know what the Koebner's phenomenon was. And so I had to look for it, and that I put it down for you guys. It's the formation of some psoriatic skin lesions on parts of the body where a person usually does not develop psoriasis. So be aware that something like these things can happen. They are usually very temporary, and they are usually self-limiting, except minor cases. So the same authors that produced this article conclude that if you do RFA of the cervical and medial branch nerve blocks, they are effective in abolishing neck pain, usually secondary to cervicogenic neck pain or cervicogenic headaches in appropriately selected patients. And as I said before, for them, an appropriately selected patient is 100% pain relief after a dual comparative medial branch blocks with different local anesthetics. Again, we can debate whether 100% pain relief is completely achievable or not. Personally, I've done this for 16 years, and I've never seen one single patient achieving 100% pain relief. As I hope I have shown to you, the procedure carries some risk. Most of them are minor and temporary, and you have to be cognizant of the fact that there are other risks that can be much more serious, complications that can be much more serious that have been reported. And the point that these authors want to make is that if you rigidly follow the guidelines put forth by the Spine Intervention Society, usually you will have none of these serious major complications. And I think that that's it for me.